I hope everybody had a good lunch. Did you eat well? So, what we will go through now, I believe the most important minimally invasive technique that everybody is doing it now is the posterior TLIF, discectomy as well. Also the microdisectomy and endoscopic disectomy. And now the new trends in the market, which is the anterolateral, like the XLIF. So we have to understand first what is minimally invasive surgery, MIS, and what is the challenging. So once you understand these points, then you can avoid the complications. And once you avoid the complications, then you can have a better outcome. So many companies in the market now, they are competitors now. They are trying to introduce new systems with some ideas that solve the problem. Unfortunately, until now, I couldn't find a real company that I can say, okay, this is the best. So it depends of your understanding to the pathology and understanding to the system, then you can use the proper system and the proper approach to get the better outcome. Minimally invasive surgery, it has been introduced to address morbidity associated with the traditional open approach. So it's supposed to be a solution for the complication we are going through with open surgery. First, it's applied for the degenerative type of disc, and with the time, it has been increased the use of the minimally invasive. It went to the treatment deformity, and also it's good and effective as well to treat coronal deformity. That was the previous beliefs. Now, with increasing our skills and exposure to the cases, we found that this is just part of the indications, or we can even expand the indications for minimally invasive surgery. So, minimally invasive, actually, they define it different way, but I found this definition is the best. It's a small incision, you do it, to gain access to a particular area of the body that need to be treated and dealt with. And this is what we call it now, the target surgery. And target surgery, you are causing iatrogenic trauma, especially with the MIF. And as we mentioned before, you have to choose the approaches, either anterolateral, posterior, fixation, fusion, microdisectomy, endoscopic disectomy. It depends on what is the pathoanatomy. Sagittal balance is very important. And the reason why, if you don't gain a proper sagittal balance, patient always come and complaining of severe pain. I have done few cases revision because of the PI, for example, not just only the sagittal balance. They came back complaining of severe pain. Then I have to readdress again the complications and try to correct the sagittal balance. Why? Because early fatigue, if the sagittal balance you did not restore it, intolerance to stand, and patient start with walking with compensation through the other joints, and then you go through another severe pain. So these are your targets for when you do the surgery: the sagittal vertical axis, pelvic tilt, coronal, and you have to maintain these numbers to get the better outcome and results. Like this one, you see, I did this case with minimally invasive, and if you can see, I did TLIF at least 5 levels in this case. And also, what I have done here, because this patient had some sort of osteoporotic issues, so I put expandable screws, the osseo screws, and I put the side here. But because I forced the correction of the sagittal balance, I was looking for perfection. What I did, I end with the loosening down and severe pain. So I have to take the patient back and remove the side screws. I don't recommend side screws now anymore when you do a surgery to have a correction of sagittal balance with a long segment fixation. It's better to use a sacroiliac in this situation. So what is your target? Why you are doing MIS? You can ask even the patient what you are looking for. If the patient, he said small scar, he doesn't like the scar in the front, he doesn't like the scar in the back. This can also interfere with your decision. So, MIS better. It avoids large incision, reduce the force of retractors, and then you don't have the muscles necrosis and pain from the surrounding tissue. Less amount of dissection, bleeding, even the pain, it's much better. But one of the problems with the MIS, when you do it, you have to practice, and don't do overtension to the skin, because you avoid necrosis for the muscles, but with minimal invasive, you might end with skin necrosis. So it's very important, the timing, the force of the tension of the skin, you have to be very careful. And this is one of the decision, I think it is wise. When you do also the TLF in the back, increase the incision. I found sometimes I have a problem when I put the tube, I'm trying to approach and do the, taking the facet out and the pars, I don't have enough space. When I cut from the side, about ½ centimeter, it gives me a better view. So sometimes don't keep over tensioning the tubes. Just increase the size. It's not going to harm if you increase the size about ½ centimeter with better outcome and to avoid necrosis. And you might injure the nerve while you're doing the surgery with very narrow, especially L5, S1 level. So, challenging trauma. Yes. Now, I'm just showing this an example. This is totally minimal invasive has been done. And you can see there is a translation, there is a lateral, there is a rotation force in this case, and it has been done by minimal invasive. We restored the alignment in coronal and sagittal plan, and this is your target. So, when we talk about posterior MIS, you have to expose, you have to learn several times. You have to see expert guys who are doing it, because we want to avoid CSF injury, nerve injury, CSF leak, nerve injury. Also, there is the way how you do the surgery is very important. The exposure, the movement, the instrumentation. This can cause the risk of infection. So, CSF leak is very important. One of the suggestions, we are talking about ligamentum flavum. I recommend it to do it the other way of the prof he just mentioned. You take it from the side, from the lateral side, and flap it to the medial, and this way you can use it as a barrier to protect the nerve and the dura while you're doing the surgery. Once you are done, then either you suture it as the previous lecture, or you can take it out. So, endoscopic disectomy, it's a unique procedure, and with endoscopy, I have 0 complication from the side of the approach. You have to know the Camden triangle. You can do decompression, very nice. I had one case which was really interesting. After the surgery, the patient wake up with pain and radiculopathy in the other side. And I think one of the complications, it can cause edema and swelling for the nerve on the other side. So now this is the role of a steroid to apply or not, especially with the radiofrequent ablation when you use it. So very important, better view, better results. When you do the X-ray first, you have to correct the rotation in the X-ray, use the machine. Then you have to correct the caudal, cephalic, and you have to center the level, because if you move a little bit, few centimeters up or down, it will change the position of the screws. And one of the challenging here, when you do a wrong level in the X-ray, you have to do X-ray. You have to measure the levels up and down. You have a wrong trajectory. This is very important, so you have to center your X-ray. Wrong angulation, this is one of the issues. So if you don't have a proper caudal cephalic angle, then you can have also a wrong angulation. You can use even the length of the screw. It's very important. This is the most complication. So you have to look AB, lateral. You have to determine the depth of the screw. There is many instrumentation, as I mentioned, has been introduced in the field here. So you have to be familiar with the system that give you the better visualization. Distraction is very important. With the case osteoporotic, when you do the distraction, you have to maintain that the screw force go parallel to the end plate, because if you do the distraction parallel, the screw can migrate to the disc, adjacent disc, and can cause with the time adjacent level disease or loosening. You have to use something called the 3-point technique. Overload of the screw, loose of the cage. If you use a too much big cage, you look at this one. It's a busy area, and with minimal invasive, you can do even this kind of procedure. The most important thing is when you face something like that, do one side. After you finish, you do the other side. The cage itself, it might go forward. I have a case, the banana cage, it penetrates to the other side. So you have to be careful when you apply the cage. You go straight, vertical. Once you feel there is resistance, it means you reach to the end. Then you just release the handle to give you the banana to move to the horizontal line. I prefer also when we put the cage also to use, you see the system down here? This is different types. It's injectable. It's better to inject bone, not just to put bone with the forceps. This will give you a better healing. Which one you would like to go? Almost same procedure. You go with minimal invasive or open, and you're going to have the same results. So, sagittal balance. Now we talk about the side, and we'll go in the next 3 minutes with the complication of the anterolateral approach. You can see here, sagittal balance can be restored in 2/3, not all cases, but still it's an effective procedure. It gives you better corpse angles, pain score is improving. You can see the difference here when you go with the lateral approach, like an XLIF, and the incision is not really big, but the most important things, when I went looking for the complications of the anterolateral, I found it really significant. It's more related to the position, the nerve injury, psoas muscle also injury. So you have to be careful with the procedure from the front. You have to be more familiar with it. So patients from anterolateral, they go with they presented with numbness, paresthesia, and weakness. It can happen. So you have to use EMG. There's special machines when you go to the psoas. You can it can detect the nerve, so you can protect it. Sometimes even if you protect the nerve and use a dilator, the dilator by itself can cause traumatic injury to the nerve. But thanks God, this is not a permanent injury. The most common levels has been documented L4-5 level. There is something called true motor weakness, and it's about 3 to 23%. There is another type of weakness, which is the pseudo weakness, and this is from the swelling and hematoma, and usually it resolves. So you have to identify the both problems that they look at the beginning when they come to the clinic are similar. The rate of the paresthesia from 7 to 30%. Numbness, it's between 8 to 42. It depends from the literatures that they have documented so far. So this is the nerves which has been, the sensory nerve has been affected, the genitofemoral, lateral femoral, cutaneous, anterior femoral. So usually in 50% of these recovered in the first 3 months, but in 1 year the recovery can go up to the 90%. So don't panic when you have it, just wait and see the result. Abdominal wall paresthesia like pseudo hernia, this is one of the identified complications, and you have, when you do the dissection, you have to be careful that you don't denervate the nerve, don't use the cautery too much. There is also another complication like colonic pseudo-obstruction, or Ogilvie syndrome. This is it's a very dangerous. Mortality rate has been documented between 50 to 71%, and it can cause occlusion. You can identify it by X-ray. You can see about 9 centimeters. There is dilatation of the cecum, or by CT scan. Sometimes they are using newstigmine or acetylstrate inhibitors. Lateral incision and hernia, it's about 1%. And the recommendation after you finish the surgery, you are twisting the patient to the side, just correct, so you can have a better closure. And one of the problems, and I face this kind of problem, is the proximal junction failure or kyphosis. The problem here, either you put the cage is too big, the cage, so there will be a migration and subsidence, or sometimes when you do a posterior decompression, posterior column osteotomy, and you do the anterior cage, this can lead sometimes also to kyphosis. Subsidence, as we mentioned, it's about, in the anterior, it's about 14%. And only out of that 14%, only 2% of these patients, they have symptomatic subsidence. Rhabdomyolysis, it's a rare complication, but very, very important with the destruction of the muscles, and it's also fatal. So what I need